How coffee can?
Can you see my slides?
Yes, please go ahead.
Oh, is it moving?
Yes, you are audible as well as your slides are also visible.
Yeah. Okay. Thank you, sir. So at the outset, I would like to thank the SVNIRTAR and Dr. Pabitra Sahoo sir to give me the invitation to talk on this topic. Uh, and at the same time, I want to thank organization IAPMR. So I'd like to start the topic of bone health in spinal cord injury. So may I know how many of the audience are postgraduate students here? You can see in the chat box.
This webinar is meant for the postgraduate students as well as young
Okay.
physiatrists.
So I'd like to keep it as a didactic talk. So please answer my and respond whenever you require. So the bone health and magnitude of osteoporosis in spinal cord injury. So osteoporosis is almost universal in spinal cord injury patients, starting from the day one. From the injury, patients with spinal cord injury experience bone loss, and majority of the bone loss occurs below the neurological level, which is also called as sublesional osteoporosis. So patient with paraplegic or most paraplegic, their bone mineral density will be preserved in the upper limb, and there will be mostly osteoporosis in the lower limbs. And a substantial amount of bone loss predisposes them to increased risk of fracture that classically we see in the around the knee joint. And the bone resorption that starts soon after the spinal cord injury, that is as soon as within the 2 weeks, and it peaks in 2 to 4 months, and it reaches at steady state by 1 or 2 years. And patients with tetraplegia and those with complete injuries, Asia A, Asia B, women, longer duration of injury, and benzodiazepine use, they are more prone to have significant bone loss and osteoporosis. And spasticity is a factor which is protective from the bone loss. And now coming to the fractures. So most fractures following spinal cord injury are considered fragility fractures, or also called low energy fractures. And because they are associated with minimal trauma, and most of the time they remain unnoticed, and it occurs while transfer from the wheelchairs and during the stretching, during the exercise. And as the patient does not have the sensations, they hardly complain of pain. So there will be swelling at the site, and you have to be very vigilant to identify any imminent fractures in spinal cord injury patients. So we can see that as many as 70% of individuals with spinal cord injury will sustain a low impact fracture at some point following their injury, and usually it occurs at around 9 to 10 years. So as the duration progress, you can see first 5 years the risk of fracture is lesser, and as you go to 7, 8, or 9, 10 years, the fracture risk is increasing. Just I'll talk about the molecular pathway of bone metabolism. This is the normal bone metabolism. So we have three types of cell in the bone. The majority are osteocytes. So 90% of cells in the bone is osteocyte. And the bone formation cells, they are osteoblast, and the bone resorption, or they are called osteoclast. So what happened, this osteoclast, they arise from the microphage, and this osteoclast, they have a receptors on their cell surface that is called rank, RANK rank. And this osteocytes and osteoblast, they release rank ligand. When the rank ligand attaches with the rank which is present in the cell surface of the osteoclast, they activate the osteoclast, and it causes bone resorption. So this same thing is counteracted by the osteoblast, which releases osteoprotection, or it's called OPG, or osteoprotogerin, that blocks the rank ligand to attaches with the rank in the osteoclast. and that prevents the bone resorptions and helps in the bone formation. So here, rank and rankel ligand that stimulate the bone resorption, and OPG or osteoprotogenin that inhibit the bone resorption. This is now the coming. So just told about the molecule sclerostin. So sclerostin is again a molecule which is released, the protein actually, which released from the osteocytes, classically only from the osteocytes, and it inhibits the WNT pathway of bone formation. So WNT beta catenin is a molecular pathway which helps in the bone formation. That pathway is inhibited by the sclerostin, and at the same time, osteoblasts they releases the osteoprotogenin, which I told earlier. The slides that osteoprotogenin that prevent the bone resorption. So, what are the pathophysiology of bone loss in spinal cord injury? So, you can see the local factor like mechanical unloading. So, as soon as the patient's spinal cord injury, they become bedridden. So, there is a reduced mechanical signals, and this mechanoreceptors, which are the osteocytes in acute spinal cord injury, they causes greater sclerostin levels, which causes more bone resorption and reduce the bone formation. That leads to a decrease in bone mineral density. So this is a rat model. They just try to look up the sclerostin as a bone mechanotransduction. So in the left hand side, you can see a picture where they have taken the ulna of a rat and they have given mechanical pressure. So they put the load on the isolated ulna, and on the right side, picture B, they make the rat hanging from the tail so that offloaded the hind limb. So rat can move around with their hands, but there is offloading of the spine and the legs. And a right-sided picture, they did a histopathology from the loading and the unloading bone. So the yeah, you can see the cursor, I think. So here the non-loaded bone, you can see the histopathology, and this is the right. This is the loaded bone. There is no difference in the bone cortex. But when they did the staining with the immunohistochemistry, you can see the sclerostin, that level has increased in the non-loaded bone. So non-loaded bone, there is an increased sclerostin mark take up, and in a loaded bone, there is hardly any sclerostin. And we know that sclerostin helps in the bone resorption or and bone osteoporosis. So that is mostly the theory behind why the patient with spinal cord injury in the acute spinal cord injury there is a maximum bone loss because of the immobilization, and sclerostin is very tightly regulated with the mechanoreceptors with the loading and unloading. And another theory is the hormonal dynamics, like suppression of parathermone. We know parathermone is controlled by the serum calcium level, and bone is the storage of the calcium. Immediately, as soon as there is a spinal cord injury fracture, all the calcium is released from the bone to the serum. So this there is hypercalcemia as well as hypercalciuria that suppress the parathermone level, and there is reduced bone modeling. And the second factor is the low vitamin levels because the reduced sun exposure following the injury, increased cortisol levels due to stress, and there sometimes post spinal injury there is a steroid used during the course of treatment. Now coming to what are the methods of bone mineral density estimations? We know the common method is DEXA scan, which is easily available, uh, and we can measure the osteoporosis. Mostly is used for the postmenopausal osteoporosis. We use two scores. One is T score and one is Z score. The T score, which level when it is below minus 2.5 standard deviation, then we define as osteoporosis. All of us know that. And when it is minus 1 to minus 2.5, then there is osteopenia. So and Z score or Z score that compares the subject's bone mineral density with mean BMD of adult of same age, gender, and ethnicity. So when we say that check the T score compare your BMD with the young adult population at the age of 25, 20, 30. And G score when you are comparing at the same age, same gender, and same ethnicity. So what are the other methods of DMD estimation? This is the peripheral quantitative computed CT scan. That is very accurate, but it is expensive as well as more ionizing radiation. Calcaneus ultrasound, that is also a sensitive modality for measuring bone mineral density in the early phase of post-spinal cord injury. This is a newer technique. It's called trabecular bone score that can be easily measured from the same DEXA machine that usually just check the lumbar scan. It will take a lumbar scan DEXA, and from there they use a separate software for that, and they can use the get the trabecular bone score. So we know that once you start treatment, mostly trabecular bone formation starts earlier than cortical bone. So TBS is a very good marker when you are giving the treatment to assess whether your treatment is effective or not. Now coming to the bone markers, so we know that there are some molecules which acts when in the bone resorption phase and some helps in the bone formation. So bone resorption markers most commonly which are used, those are CTX or carboxy terminal peptide and NTX in terminal peptide. These are nothing but degradation of the type 1 collagen, CTX and the NTX, which is commonly measured in the serum. And markers of bone formation are osteocalcin. This is not very sensitive. Alkaline phosphatide, bone specific alkaline phosphatide, and serum procollagen type 1 peptide or PINP. Now, coming to the bone markers in the acute spinal cord injury. So, bone markers can be tested as early as 3 months after starting the treatment or even at the acute phase that to check what is the bone turnover. And the role of repeat DMT is not proven to correlate with the reduction in fracture risk. So, bone markers are it can be checked to check the bone turnover, but it is not effectively correlate with the bone mineral density. And so, bone resorption rate is higher than bone formation rate in the acute phase of spinal cord injury. This is a study from the CMC Vellore, which is done by Thakkar et al. Uh, it showed that they just did a bone evaluate the bone turnover markers in individual with acute spinal cord injury were at less than 1 year, and they measured bone markers at baseline, at 3 months, and at 6 months of spinal cord injury. And they showed that there is a significant elevated levels of bone turnover markers at the third month of ACI. You can see that ACI patients, the sweet elopeptide is 1494, and osteocalcin in the patients are 30, which is more elevated in the that 3 months of post spinal cord injury. Now coming to the sclerostin. So sclerostin sometimes they consider that it can be a biomarker for ACI induced osteoporosis because DEXA has quite a few drawbacks when you check the bone mineral density in spinal cord injury patients, because DEXA-based diagnosis is you know a little clinical utility because it hardly gives any fracture risk prediction, and the site of bone loss, which is proximal tibia and the distal femur, in standard DEXA we don't check those levels, those areas actually. So that's why sclerostin comes to the picture, and it's a protein which is produced exclusively within the bone microenvironment. It is secreted by the osteocytes. And so this is one study done in 2014. So they checked the age as adjusted cholesterol levels in chronic spinal cord injury patient, and they found that cholesterol level was positively associated with the bone mineral content. So you can say that mechanical unloading, or when the patient is in the acute phase of spinal cord injury and the patient is bedbound, That subject to cause greater sclerostin level. And in chronic spinal cord injury patients, when there is a bone mass is completely lost, so there will be decreased sclerostin. So in the acute phase, when there is a rapid bone resorption, your sclerostin will be at greater level. And in chronic spinal cord injury, when the bone resorption has more or less stabilized, there is hardly any bone mass, there will be lower sclerostin. So if you check the serum sclerostin level, that can give an idea about what is the level of osteoporosis in the spinal cord injury population. Now, come to how to prevent bone loss in spinal cord injury. So, just coming to the drugs, bisphosphonates are widely used in the management of osteoporosis in post-menopausal patients as well as in secondary osteoporosis, like spinal cord injury osteoporosis. So, it inhibits the osteoclast-mediated bone resorption. And we know that zoledronic acid is the most potent with that, which is the third generation bisphosphonates. Now, there are some studies I want to tell. One is Snyder et al. That showed that positive effect of zoledronic acid on bone density of distal femur, though it was not statistically significant. The investigation of Barman et al. They also looked for bone loss. That showed that zoledronic acid reduces the bone loss at the hip, but not around the knee. But we know that majority of the fractures occurs at the lower limb, that is around the knee. And the reduction in bone loss, which is checked by the bone markers in the acute phase after pamidronate and zoledronate administration, that has been reported in some studies to be temporary, lasting for 6 months to lasting hardly for 6 months. And an oral bisphosphonate, which is alendronate, that can be also administered 70 milligram per week or 10 milligram per day over 6 months, but it attenuates bone loss by 9% when administered for 2 years. So this is the study which is effect of early treatment with zoledronic acid on prevention of bone loss in a patient with acute spinal cord injury. This study is done from SMS Jaipur by Goenka et al. So they have taken a huge number of patients, almost 60 patients with acute spinal cord injury, and they looked after the aerial bone mineral density that is measured with the normal DEXA. They did a mainly classically hip DEXA. They did at baseline at 3 months, 6 months, and 12 months. And there was significant difference in aerial BMD observed between the groups at 12 months at the femoral neck and the total hip. But there is no significant difference in bone mineral density between the groups are observed at 3 months at any of the sites of the hip. So they showed that there is a aerial bone mineral density is better at 1 year of post zoledronic acid. Now coming to the few basic about bisphosphonates. So when to give bisphosphonate and how to prescribe that. So first, before prescribing bisphosphonate, you have to check patient's calcium, especially corrected calcium, kidney function, and ECG prior starting. Vitamin should be D should be started prior to bisphosphonate because we have to make sure that the patient's vitamin D is normal before giving bisphosphonates. And there is one severe adverse effect which is a rare side effects although osteonecrosis of jaw. So before prescribing bisphosphonate to make sure patient not have any caries tooth and any dental procedure ideally should be avoided when patient is on bisphosphonates. Now when to stop bisphosphonate. So there is no recommendation or clear-cut guidelines, but it should be given at least for 2 years. And we can look for the bone markers. If they are not very high, if they are stabilized, then you can reduce the or stop the give the drug holiday for the bisphosphonates. And there is no role of DEXA to repeat after starting bisphosphonates. Even DEXA can be done after 3 years or after 5 years also. Now, this is the spinal cord injury research evidence, CAR evidence, that says that the efficacy of the drug, I'm talking about the bisphosphonates now, the efficacy of the drug intervention appears to be greater when administered early after its onset. So, because we saw that Majority of the bone loss occurs at the acute phase of spinal cord injury. So if you have to stop that, you have to do the intervention at the acute stage or early stage. And oral alendronate once a week, it maintains the BMD at the hip. Uh, Once yearly IV infusion of zolidronate that may reduce the bone loss at the hip during the 12 months following administration. And alendronate 10 milligram daily and calcium 5 milligram orally 3 times a day is effective for the maintenance of BMD of the total body, hip, and knee region for the main with paraplegia. Now coming to another drug that is denosumab, which is currently popularly available almost for majority of the osteoporosis which we see in the practice. So this is a study. So denosumab is a monoclonal antibody. It acts on the rank ligand. So rank ligand, and it just prevents rank-rankel binding and prevents osteoclast-induced bone resorption. So dose is 60 milligram at subcutaneous at every 6 months we can give. So here the Christopher et al. The study was published in 2020. So they took 26 people with subacute motor complete spinal cord injury, and they prescribed denosumab and placebo, the randomized control time at baseline at 6 months and 12 months. And they checked the DEXA at 18 months at the distal femur and then proximal tibia. So they gave up to 1 year and they checked DEXA at 1.5 years. So here's the result. So you can see that at the distal femoral metaphysis and the denosumab group, the baseline DEXA is 1.187, which became 1.202. We can say that it is maintained even after 1.5 years post spinal cord injury. And for the placebo, the DEXA VND value was 1.16. That reduced to 0.961 at 18 months. And at proximal tibial epiphysis, denosumab group had BMD of 1.071, which remains 1.05, and that is statistically significant. And in the placebo group, there is a reduction from 0.99 to 0.76. So from this study, we can see that denosumab can maintain the bone mineral density of the around the knee joint. Now, what happens if you discontinue denosumab? So this is you can see the red line is denosumab group. They gave 30 milligram at every 3 months. The yellow dotted line, that is the alendronate, 70 milligram once a week, and this is the placebo. So they gave the treatment at 0, 3, 6, 12, 18 months, and they stopped the treatment was discontinued at 24 months. So you can see what happens to the denosumab group. Suddenly the BMT dropped to the almost where you have started. For the alendronate group, they stopped the alendronate at 24 months, but almost it continues to be same level or slightly reduced, but not like denosumab after discontinuation. And this is the placebo. So this is we checked on the lumbar spine BMT. Now they restarted the denosumab therapy at 36 months. So when you restarted it, immediately can picked up. Within 1 year, it picked up to what you are at 24 months. But Alinonate, they have not restarted. Alinonate, after stopping, they just looked at 48 months. It means almost stabilized. And placebo group significantly started reducing. So here we can say that once you stop denosumab, you have to be very careful because there is a sudden spike of the bone resorption, and there is increased risk of osteoporotic fracture once you discontinue denosumab. Here they look after the hip BMD, and here you can see hip BMD does not respond as good as lumbar spine BMD in both denosumab and alendronate group. But similar result once you stop denosumab, it's reduced, but again it picked up. Alendronate, anyway, after 48 months, it remains almost stabilized, but it is BMD was lesser than the denosumab. And in placebo, definitely it is way below than the denosumab group and the alendronate group. So from this, we can come to this conclusion that denosumab is very effective to maintain or maybe to increase the bone mineral density once it is given. But as soon as you stop denosumab, the bone mineral density drastically drops. And to prevent that, most probably you have to supplement with some kind of other oral agent or bisphosphonate groups. So what I told earlier, the study denosumab in spinal cord injury, where they looked up at 0, 6, 12 months, the same group, Christopher Sirlingo, they just continued the study. So they gave, this is the earlier study which I was talking about. This study, they did, so they gave denosumab at 6 months, at baseline 6 months, 12 months. They followed up at 18 months. So in 18 months, they showed that BMT is maintained. The same group, they just followed up those patients and they published this study in 2023. They showed that all the regions, the BMD, hip, and the knee, at 30 months, they were similar to the placebo group. So again, what I told earlier, earlier slides that when they discontinued denosumab after at 30 months, so they gave the last dose of denosumab at 12 months, and at 30 months it became almost same as placebo, the bone mineral density. So denosumab. So before prescribing denosumab, you have to be very careful whether the patient can afford the drugs. Patient can maintain the drugs for quite a long time. And if you have to stop denosumab, to look after, check the bone mineral, bone density, bone turnover markers, and you can switch to oral or IV bisphosphonates. Now, what are the role of physical activity and bone loss? So there is a level 4 evidence from people's study that walking and the level 1 evidence that standing in the acute phase did not differ from immobilization for bone mass decline in the femur or tibia. So there is hardly any evidence showing that therapeutic standing helps to maintain the BMT. This is the body weight supported treadmill training in acute spinal cord injury patients. And they say that twice weekly body weight supported treadmill training appeared to be partially reverse the muscle atrophy after the spinal cord injury, but it did not prevent any kind of bone loss. So there is level 4 evidence from one paper study that activity-based training, 2 to 3 hours per day, for a minimum of 2 days a week for 6 months, that increase the spine BMD. But again, spine BMD is hardly affected in case of spinal cord injury patients. Because most of the patients, paraplegic patients, they tend to sit. So because the loading in the spine, that hardly changes. Now there is inconclusive evidence for reciprocating gait orthosis, long leg braces, or passive standing, or self-reported physical activity as a treatment for low bone mass. Need further studies for that. And there is no evidence to support physical activity as a treatment for low bone mass after spinal cord injury. Now, this is EPS-based activity to prevent bone loss in spinal cord injury. So, EPS means functional electrical stimulation based either standing or rowing. These are the activities to prevent bone loss. So, these are the studies showed either poor evidence or fair evidence to prevent bone loss in spinal cord injury patients. Now coming to a new drug, which is romosozumab. So this is a monoclonal antibody against the sclerostin. So sclerostin we talked earlier. So sclerostin just inhibits the WNT signaling pathway, and it causes bone loss. So it causes bone resorption. So the antibody against sclerostin is romosozumab, and it promotes the bone formation as well as bone resorption. So it is anabolic agents like teriparatide. So, what is the take-home message from the talk that bone loss in spinal cord injury that occurs maximum at and probably. So, usual DEXA, what we do that checks the region of interest at the hip, at the lumbar spine, protocols to check the distal femur and the proximal femur. There are some studies going on, but still there is no guideline has come for the how to check distal femur and proximal tibia. And bone markers give better information about the bone health in case of spinal cord injury because you know that maximum bone loss occurs at the acute phase, and to transform that into reduced BMD index, that will be after 1 year or 2 years. And even if you see the patients with chronic spinal cord injury, they have fracture also, their T score may not be changed. And sometimes it is difficult to assess a DEXA of a spinal cord injured patients because it is difficult to transfer as patients. Sometimes they will have a contracture in the legs, so you cannot position the leg properly. And if they have a heterotopic ossification, again the value will be deranged. Sometimes we check the lumbar spine BMD only. So anyway, because of the loading or because of the screw fixation or osteophytes, the lumbar BMD will be erroneous. And one more findings from other studies that whenever they did a BMD of forearm in spinal cord injured patients, they found that the bone mineral density is significantly better than the control groups in case of forearm BMD. And you have to be careful before initiating denosumab. Also, treatment um, just because we have available therapy like teriparatide denosumab, but to careful about what to start. You have to discuss with the patients that these are the probable therapy means you have to take it every 6 months or continuously. Difficult to discontinue. So to assess, you have to talk to the patients, and then only you can start denosumab. So now this is the my acknowledgement. I would like to thank all my teachers, starting from my undergraduate, my postgraduate students, postgraduate, and my fellowship programs. And whatever I learned, most probably during my residency and the fellowship programs with the bone loss, and my colleagues, most probably they have done several studies in bone health in spinal cord injury patients in same Sekolah. And this is the current working at the Department of Neurodegeneration at Institute of Neuroscience, Kolkata. These are our team. So Dr. Suparno Ganguly, Dr. Saha, and myself are the consultants, and there are almost 70 therapists working as a team. We cater mostly all sorts of patients come under the PMR or neurorehabilitation. So with this, I'd like to just conclude my talk and can go for the discussion, whatever the questions you have.
Yeah, that's an extensive way of presentation with good evidences uh, with respect to the topic. So we have few questions in the chat box. Let us take one by one from the chat box. One question is, what is the dose of zoledronic acid infusion and dose frequency?
Okay,
Is it
so
is it more frequent than post-menopausal osteoporosis?
okay, so zoledronic acid dose is the same as postmenopausal osteoporosis. It is 4 milligram or 5 milligram. You can keep. It's IV. Should be given over 30 minutes to 1 hour under supervision, and it is once a year. And usual low monitoring is required, but there is a chance of anaphylaxis. Even we see one patient with delayed anaphylaxis, like we gave zoledronic acid, patient went home, and after the next day, patient came with a rash. Usually, these anaphylaxis are it can be controlled with simple levocetirizine or montelukast tablets. But you have to be careful before giving zoledronic acid. You should check for the serum calcium level and the serum phosphate, because if the calcium is low, it can reduce the calcium further, and the creatinine or renal function should be checked. Otherwise, it is very safe drug. Can be given.
Can both bisphosphonate and denosumab can be given simultaneously?
So this is a good question. So as per recommendation, that is
Hello?
International Clinical of Densitometry. Hello, am I
My
audible, sir?
question, can both, yes, can both bisphosphonate and denosumab can be given simultaneously?
Yes, yes, I'm answering, sir. So as per recommendation, combination therapy is not advised for any kind of osteoporosis. So it should not be given. But anyway, if you want to, if you're continuing denosumab and you have to stop, then definitely you have to couple with uh, any kind of bisphosphonates, but not a combination.
Okay, then when somebody asks for option, as per your evidence you have shown, uh, this denosumab, it once it's stopped again the beam is coming down. So in other way, the second curve shows about the alendronate, sorry, alendronate. Can it be a drug which can replace denosumab, which is maintaining and is low cost?
So then this study, what it's showing, can you see my slides now?
Yes, sir, we can see it.
Yeah, so here it is showing that the yellow line, that is the oral alendronate. So alendronate can maintain almost the bone mineral density, even if you stop it at 24 months.
Yeah.
Even if you stop it at 24 months, your bone mineral density is not significantly reducing. So, but anyway, denosumab is much more potent than the alendronate. But the negative effect is because the you are stopping the rank-rankle ligand by the denosumab. Once denosumab is stopped, these receptors become like hyperactive, and it causes rapid bone loss.
Hello.
Hello, hello.
Yes, yes, please.
Yeah, can you hear me, sir? Oh,
Now we can hear you. In between, there was some signal problem. Now we can hear you.
okay. So what I was saying that other than denosumab, you if you want to replace it with someone, then I think oral alendronate or IV zoledronate. IV zoledronate also, if you compare the cost benefit analysis, this is also very good. It is hardly 3 to or 4,000, and dose is like once a year. And so compliance is better than oral alendronate.
Okay. Any idea about event? Also quite common drug use, which is used
Yes,
once in a month.
alendronate also 150 milligram once a month. It is given, but alendronate does not have any effect on hip BMD. Sir. It maintains the BMD of the spine. So what I said that spinal BMD or lumbar spine BMD, that is not much reduced in case of spinal cord injury patients
Right,
because of the loading.
right.
So Ivandronate has has minimal effect in spinal cord injury osteoporosis.
One question in the chat box: which bone marker is the best for assessment, and what is the cost of the test?
Okay, so I am not. I cannot say about the which is best, but what in my practice, what I have seen that CTX is used for the bone resorption marker, C-terminal telopeptide, CTX, and for the bone formation, PINP or pro-collagen type 1 peptide, and peptide. And cost is less than 1,000 rupees. Serum, it is easy, it can be done, and it is a serum marker.
Can you repeat what is that test, serum marker?
Yeah, as a CTX or C-terminal CT telopeptide.
Okay.
You can just go.
Is there any drug which will be useful for pediatric spinal cord injury patients or osteoporosis?
Okay, sir. Sir, I could not read any kind of studies on pediatric osteoporosis. So this is the marker which I told.
Mm.
This carboxyl terminal, or it just write it CTX, like it is written as NTX, N-terminal telopeptide. This is the C terminal of telopeptide, or CTX is the bone resorption marker. And for bone formation marker, you have to take procollagen type 1 peptide.
Any recommendations for management of acute lower extremity fractures in spinal cord injury?
Yeah. So the you have to first prevent the complications, because first of all, to detect the fracture, it is sometimes majority time it is unnoticed. Even during my residency, we remember two or three patients we found out on the next day. So patient underwent therapy, and somehow during transfer had some injury, some trivial injury. And next day we noticed that there is some swelling. And so first of all, early detection. So you have to be vigilant about any kind of undue movement or swelling is appearing or not. And other complaints that can come, it can cause sometimes venous thromboembolism or fat embolism. And prevention part is same as normal long bone fractures. How do you take care? Immobilization followed by, if you see that patient has a potential to walk, then you can fix it. Otherwise, you can just let it immobilize, and with the closed casting, it can help.
Is there any role of teriparatide, parathyroid hormone for any
Yeah, yes,
people?
teriparatide is a bone. It's a abaloparatide or parathyroid analog. So it is bone. So I actually have not included this on my topic, but it is uh, it is used subcutly for 3 months. But again, drawback is that once you reduce or once you stop, again there will be rapid bone resorption, and it has a remote chance of bone carcinoma, especially osteosarcoma. So because of all this risk, I think there are better alternatives to use for the
But
osteoporosis.
teriparatide very commonly used in fracture conditions also, not in fracture conditions also.
Yes, yes, sir. So it's widely
Uh,
used.
One more question on this regarding this physiological standing. You know, all your papers on you have shown whether it is a body weight support training system or
Yes.
any form of physiological
Well,
standing.
evidence
Uh,
is poor, although we have to do, because what I said in the first, that sclerostin. The sclerostin is like tightly regulated with the weight bearing. So here in the rat model, they have showed nicely that once the part of the rat which is unloaded, there is high level of sclerostin induced bone loss. So if you go with the theory of this, then definitely you have to make the patient go for therapeutic standing, although the evidence is poor.
right, that's an issue. It is not. It is. I think muscle pull is more acting here for getting the bone instead of only loading. So we have
Yes,
working muscle pull here. Loading is there. Yes, loading also helps in some extent maintain the bone density.
yes. So and it has also positive effect on the muscle mass. The lean
Yes.
muscle mass is significantly reduced, and it is replaced by the fat, and that causes again insulin resistance, and that mediated bone loss. So this therapeutic standing also has some positive effect on the to maintain the muscle mass, or to prevent, at least to prevent the loss of muscle loss.
One more question, chat box. Is giving iodine for prolonged duration the best cost-effective pharmacological method for spinal cord injury bone loss? It's very cheap iodine in comparison to all
Yes,
bisphosphonates. Can we give as a routine therapy for a long period instead of when the person cannot afford for denosumab or teriparatide and other other bisphosphonates?
I think too. In our socioeconomic status, definitely even the DEXA scan is also expensive, and majority of the patient cannot afford a DEXA scan, which cost around 2,000 rupees. So for them, I think even in after 6 months, after 1 year, you can blindly can start alendronate, 70 milligram once a week. But if you see the cost, I think 70 milligram per day for per week, it comes about at 50 rupees or 60 rupees.
Right, right.
Yeah,
It's
if you
cheaper.
combine about with the 52 weeks, I think then bone your Zolidonate may be cheaper sometimes, and it is
In
more.
long run, if you calculate per year
Yes,
cost,
yes,
maybe
sir.
that will be cheaper.
And I have seen many patients forgets to take the medicine alendronate. The
Right, right,
compliance is
right,
an issue,
right. Mm.
and sometimes it causes
Eruption
esophagitis or
also,
peptic
acid
ulcer.
eruption. Mm.
So you have to give the proper instructions. So before you have to take at empty stomach to get up. You don't have to lie down. To take 200 glass of water.
If walking or weight loading twice a week doesn't help, then what should you do non-pharmacological methods? Question is not actually clear. Hello.
Yes,
If
okay.
walking or weight loading
So
twice a week doesn't
it does
help,
not help means as per. Yes, sir. I can read the question. So this see walking, it does not prevent the bone loss, but it what I said that it sometimes prevent the muscle loss or lean muscle atrophy. So there are other positive advantage of therapeutic loading than bone loss. And the studies which are done as per that, the evidence is poor, but not necessarily that we have to completely cut down on therapeutic standing. So there are other positive. It prevents muscle contractures. It reduces muscle spasticity. So all those positive effects also you have to take care of.
okay, thank you very much. I think there is no more questions in chat box, and it's already time also 8:30. Thank you very much, Dr. Gaurav, for
I think
giving
that there is one question that
inputs.
is,
Yes, is there any further questions here in the chat box?
yeah, the is alendronate should be given to all SCI patients.
Yes, yes.
I can see this question. So see, it is
Just
not
now we
to all
discussed,
the
I think
patients.
that
Ideally, yes. So DEXA should be done. Okay, but if at all patients is not able to afford that, yeah, at after 1 year of age, you can give alendronate, but ideally DEXA should be done, and then only. And DEXA of the our region of interest is the knee. Okay, distal femur and the proximal tibia. We should not see the DEXA of spine or forearm and just go for the alendronate.
thank you, Dr. Gaurav. So you
Yeah,
accepted invitation. You have presented a very beautiful talk, which rarely we think about the bone part. You always think about other comorbidities. And your presentation really with a lot of evidences why you should prescribe this drug and regarding pathology also. That's a really nice presentation. Thank you very much once again. And I must thank all the participants, all the whoever have joined this webinar. And I must thank the office bearers of IAPMR and the PR team of IAPMR who is providing us this Zoom platform for conducting this webinar. I hope in future also we'll continue this work with good academic subjects. Thank you all once again for joining this webinar. Thank you very much.
yeah, yeah. Thank you, sir. Thank you for your tedious effort doing this webinars almost consistently for almost past 2.5 years. And I was also resident. I used to see all these webinars. Those are very helpful.
Thank you. Thank you very much. So we can close the session now.
Yeah, thank
Thank
you,
you.
sir. And
Thank
thank
you.
you, everyone.